So again, after my first slide, the same doctor, can you please again comment? Who was the doctor who first comment? Dr. Hasika or who? Oh, she's not there.
Ma'am, this is Ramya. Actually, Dr. Hasika went down to attend a patient, so she'll be joining soon. So she's not right here.
Okay, so
Yeah,
after my first presentation past time, I hope it will modify her answer to a better answer. Can you please try? Start with the left.
So I see on the right side of the slide, I can see a picture with the, with a graft, corneal graft, which is placed in the center. I mean, centrally placed, with the sutures intact, and they all the suture. I mean, the knots seem to be buried.
Yeah.
And with an optically clear graft.
Is it clear? Anyway, I think in viva exam, we're supposed to describe only.
Okay.
Yeah. Okay, I will remind you in quick. Okay. When we comment on a graft, we should comment on the graft itself regarding clarity and centration. We should comment on the interface, if the wound is coacted or if there is any gap, type of the graft. We should comment on the stitches, type of the stitch, okay, and the strength of the stitch and the knots, and any other, like if there is debris or any other associated with the graft. Then we should comment on other signs in the same eye and the other signs in the other eye. We are trying to detect associations and also the cause, why this patient performed the graft. So we can check the other eye for dystrophies or keratoconus. We check the same eye if there is associated glaucoma surgery, tube, IOL, posterior anterior synechia. From the interface, scarring, and sutures, we can know the age of the graft. Okay, we can differentiate between anterior lamellar graft and the endothelial graft by the interface. And in the endothelial graft, we can see the venting incisions. We can see the temporal scleral tunnel incision and the peripheral iridotomy. Other possible presentations, graft with infection or graft rejection, epithelial or endothelial or stromal. So here, I would like someone to comment, and there is some clue that the other eye is normal. So this is only unilateral with graft. I can see Dr. Logan joined. Can you please share us? Okay, no, Dr. Logan. Roba, Dr. Roba.
Okay, Dr. Hala. This is a colored photograph showing the anterior segment. I can see a centrally clear graft with the continuous sutures. I can't see any haze. I can see, sorry, interface haze around the graft. I don't know. I can't see any other findings actually.
Okay, so back to our criteria. What are the points again? type of the stitch. Okay. What is the type of the stitch here?
Continuous sutures.
Yeah, double.
Yeah,
Yeah.
double.
Can you see any infection related to the suture? Can you see any knot? Any?
No, not really, actually. I can't see any knots or infection.
Okay. In the interface, can you get any information?
You just mentioned I can guess the age of the graft.
Okay. What do you think?
I don't think it's a recent surgery, but I can't tell how long it has the patient underwent the surgery.
Okay, so it's like some months.
I don't know, actually.
Yeah. Okay. Do you think it's deep penetrating or other?
Also, I can't tell from the picture. I need slit lamp examination to see the area and the interface. Is it deep penetrating or it's only deep anterior lamellar?
Yeah.
So I can tell from this picture. I need a slit lamp examination.
So regarding the interface, we should comment on if the wound is coapted or not. Okay. So you comment
Mhm.
the wound is well coapted. The sutures, do you feel it's tight or loose or any? Okay, so
No.
my point is that we should comment even by negative. Okay.
Okay.
So the graft clarity and the centration. Here the graft is central and clear, right? And the interface coapted, and we cannot judge the type of the graft because we need to see the section. Regarding the stitch, double continuous, I cannot, it's not tight, no, not loose. I cannot see any knots. Okay, can you see anything in the eye to know what is the reason for keratoplasty?
Can you go back to the picture, please? Maybe the limbus is a little bit pigmented. Could be VKC, keratoconus. I don't know, actually.
Yeah, it could be. So we cannot judge from this picture, but the other eye is normal. So maybe it's not keratoconus. Okay.
Okay.
So we cannot find any of these. We cannot find the vending incision. We cannot see the scleral tunnel incision. We cannot see the peripheral iridotomy. So we cannot see the interface by slit lamp. So we cannot judge the type of the graft, right? And clear central coapted wound stitches we commented already. Okay. So this one is deep lamellar keratoplasty. The ideal answer I'm going to read this corneal graft with double running sutures. The sutures are intact, no exposed sutures, no infiltrates. While we need to do slit lamp at the graft host junction to make sure it is deep lamellar keratoplasty. The cornea is clear, no any sign of rejection or infection. The AC is deep and tight. By trans elimination, no any defect, no peripheral iridectomy, nothing. Always in any patient with keratoplasty, we should check the IOP and put in our mind steroid-induced glaucoma. Okay. Usually, if we are asked about the reason, the possible reason, it could be previous scar, it could be infective keratitis, It could be any unilateral condition because he told us already clue that the other eye is normal. Fine?
Yes, Dr. Halaya.
Thank you, Dr. Buba. Okay, this one. Anyone like to comment?
Ma'am, can I answer? This is Hasika,
Yeah.
I'm back.
Yeah.
Ma'am, the first picture on the left shows the right eye anterior segment photograph showing clear lenticule. Firstly, it is probably a case of DSEC or DMEC. So I can see a clear graft. There are no clear central graft. There is no congestion. There are no sutures. The interface appears clear, ma'am, but I can't appreciate in a broad broad slit. I mean, like there should be a slit image to say the interface how it is. There is a inferior peripheral iridotomy, and the pupil is round, and probably the patient is a pseudophakic in the right eye. The right side image shows again anterior segment photograph of the other eye, the left eye, showing central stromal edema with epithelial irregularity, probably few bullae, and nuclear sclerosis, probably gray cataract. So it is a phakic bullous keratopathy, probably secondary to Fuchs endothelial dystrophy. Is it right, ma'am?
Yeah, great. Almost you covered everything. The main reason of this picture that when we see the other eye, we can confirm the reason of the keratoplasty in the first eye. So as Dr. Hasika mentioned, it is related to pseudophakic bullous keratopathy following cataract surgery for FOS cornea. Okay, and you perfect. You mentioned it's DSEC or DMEC, and as I mentioned a while ago, that the peripheral iridotomy is a sign. Okay, the graft is clear, well-centered, no evidence of decompensation. AC is deep and quiet, no KBs. The presence of inferior and the peripheral iridectomy. No any sign suggestive of glaucoma. Okay, the right eye, the other eye, the left eye, there is multiple central guttata associated with corneal edema, bully, same like you mentioned, involving the visual axis, and no stromal scarring. EC is deep and quiet. There is a nuclear sclerotic cataract, no iridotomy, no sign of glaucoma surgery. This probably the patient has had bilateral corneal decompensation due to Fuchs endothelial dystrophy and underwent keratoplasty. Thank you, Dr. Hasika. So, anyone wanted to comment?
May I, ma'am?
Yeah, sure.
So this is anterior segment photograph of the left eye, showing the eye is white and the central, nearly central graft, which is clear. The graft clarity is good. The graft host junction appears normal. There are approximately 16 intermittent sutures. All the sutures are they're normal. There is no tightness or loose sutures. The knots are all buried. The pupil is dilated, probably due to pharmacological dilatation, or it could be even urate. The condition urates. I am not remembering that there will be a condition where the pupil remains fixed and dilated, and the lens appears clear, ma'am. So this is post keratoplasty. I can't comment if it is DALK or it's a full thickness transplant because there is no slit image, and otherwise there is no KPs or everything is normal.
Thank you.
Optical keratoplasty.
Thank you, Dr. Hazim. You counted the sutures or you know?
What, ma'am? What, ma'am?
You counted the sutures.
No, I mean, there will be usually 16 sutures, so yeah. I said in a fluke.
Yeah. This one, due to some technical problem, it's not a quiz now. So we have to read together or you hide. So this is bilateral condition. Most probably Schneider crystalline corneal dystrophy, and this patient underwent keratoplasty. How we will comment on the this eye? Continuous running sutures, and there is also some interrupted sutures. Okay, the sutures are
Interrupted and continuous.
yeah, the sutures are intact, and the wound is coacted, no gapping, the graft is clear and well centered, no sign or feature of decompensation or rejection. Okay, and no peripheral iridotomy, no any sign of glaucoma. By looking to the other eye, most probably this is Schneider crystalline corneal dystrophy. Okay. We will check for steroid glaucoma, and we should test lipid profile. Anyone want to comment? Dr. Eva. Where is Dr. Eva?
Yes, ma'am. Okay.
Dr. Eva, do you like to comment?
This is a photograph showing the anterior segment, and it shows a central large graft, most probably a therapeutic penetrating keratoplasty with this is more than 16 sutures, maybe 20 sutures.
Yeah.
And there is peripheral vascularization also.
You didn't,
The anterior chamber.
Dr. Eva, you didn't comment on the suture same way we mentioned. You
The suture, the
interrupted
space between
sutures.
The type of the suture regarding the tight or not, any not seen, any associated.
Ma'am, the sutures are not equally placed, ma'am. The distance and they are not of same length as well.
Yeah.
Some are long, some are short. The spacing is not regular. The eye is inflamed. The graft is relatively clear. Like she said, there is a superficial vascularization superiorly and inferiorly. The anterior chamber appears formed, and there is a complicated cataract with posterior synechia as well. So as she said, it could be a therapeutic keratoplasty.
Okay. Anyone has any different comment?
I think this patient has posterior synechia and mature cataract, right?
Yeah. So why the eye is angry? Why the eye is so injected and congested?
It could be neovascular glaucoma with increase in intraocular pressure. Could be.
Okay. Actually, no idea regarding this photo, but we should learn how to describe, because this will be the scenario in the exam. Okay, same. This is classical, as we mentioned. Anyone wants to comment on this? Dr. Logan. Are you here? So who else want to share? Anyone? So anyone?
Ma'am, shall I?
Yeah, please.
Ma'am, the left side image shows an inflamed eye with totally opaque cornea. I can't say exactly what that condition could be. And the right eye is again post keratoplasty. The patient has a central clear graft. The size of the graft is also approximately 7 to 7.5 millimeters. The graft host appears normal. The sutures are interrupted sutures. They are.
This
Yes,
the left side photo is the same patient, the same eye before the surgery.
Oh, before the surgery and after surgery. Okay. Are you telling that, ma'am?
Yeah,
It is post keratoplasty the right eye. Okay. So it is the total optical keratoplasty.
Yeah.
Yes.
This one was fungal keratitis.
This is fungal. Okay, ma'am.
Yeah.
The left eye.
Yeah.
Okay, ma'am.
And this is
Oh.
this is deep anterior lamellar keratoplasty. Okay. Here,
Ma'am, but ma'am, a small doubt. If we are shown an anterior segment photograph like the previous one, we can't actually comment if it is a dark or a full thickness keratoplasty, right?
yeah.
Unless there is a quick image.
Yeah, sure.
So, yeah, okay, ma'am.
This one, a while ago, I mentioned regarding the venting sutures. This is the venting sutures. Okay. So if we see same like this, so this is DISIC. Okay. This is the suture by cross section. This is during the surgery. This is post the surgery. Fine. This is the tunnel. This is the scleral tunnel. Okay. This one, the peripheral iridotomy. All has peripheral iridotomy. Also in the sick.
What, ma'am? You are saying about peripheral iridotomy?
Yeah. Because
Can you go to the... Okay,
all has. And there's also the bubble. So what are the indications of keratoplasty? We have some optical, some tectonic, some therapeutic. Optical, same in patients of bullous keratopathy, keratoconus, post-corneal dystrophies, interstitial keratitis, herpes simplex keratitis, trauma, scars, failed graft, tectonic, only to cover perforation or corneal thinning, therapeutic in case of infective keratitis. These are the possible types of the graft. It could be penetrating, it could be triple procedure, penetrating keratoplasty together with cataract surgery and IOL. It could be deep anterior lamellar, it could be DISIC or descent membrane endothelial keratoplasty or descent stripping endothelial keratoplasty. We are going to mention this later. So these are the possible surgeries. This one, penetrating keratoplasty, we take full thickness graft. This one, deep anterior lamellar keratoplasty, we take epithelium and stroma. Then DMEC, we take only the descent membrane and endothelium. DISIC and DISAC, both descent stripping, either automated or not, endothelial keratoplasty. We take the posterior stroma and descent membrane and endothelium. What is the difference between the DISIC and the DISAC? The automated, we use mechanical microkeratome, but in the regular one, we do it manually. And recently, we have the laser assisted keratoplasty. We have the intralase enabled keratoplasty. In this one, the laser will cut according to pre-programmed algorithm specific depth and the specific shape of the cornea. Okay, same like this. Standard, top hat, mushroom, zigzag, and Christmas tree. Okay, this is the sick, and this is the mic. Okay, and this is the laser assisted, and this is again the laser assisted, how the shapes. This one, deep lamellar keratoplasty. Okay. We should appreciate from this picture that this one not full thickness graft because of this white line. So this white line should, and by slit lamp, it should be shown clearly. Okay. This one, deep lamellar endothelial keratoplasty. Okay. This deep lamellar anterior keratoplasty, the main concept that we have corneal lesion, but the endothelium is healthy and good. I wanted to keep it. So if we have desmatocele, if we have Moran ulcer, if we have some superficial corneal infection, any superficial lesion, it's very important in keratoconus and pellucid marginal degeneration, only alternative. In pellucid marginal degeneration, mainly penetrating keratoplasty. But keratoconus, it's the most indication. Also in cases of post-refractive surgery keratoplasia. Okay. In case of corneal scars, in case of corneal dystrophies, but it will not be suitable in macular corneal dystrophy, only in the superficial ones, Avellino, lattice, granular, in cases of ocular surface disease. Okay, in cases also corneal clouding due to mucopolysaccharidosis, the endothelium is good in this case. What is the advantage of the DALC? The DALC, lower risk of rejection, better rehabilitation, less complications than the penetrating keratoplasty. But the learning curve is more difficult, and there is interface scoring. Okay. What is the complication? Because it's technically more difficult, we could do perforation. It can also double anterior chamber when detachment, and the interface haze or scar, as we mentioned before. Okay, this is the sick. The sick, the descent membrane is tripping. This one, no sutures. Okay. And as we mentioned a while ago, we have some signs like the venting sutures, like iridotomy, like the scleral tunnel. What is this stripping? I only mentioned this steps so you appreciate if you see the peripheral iridotomy in the case they do in such a case because of a pupillary block. If you see air bubble, same. If you can see the tunnel, same. Okay. Do you like me to describe it or I pass it?
You can go ahead and pass it.
Okay. What is the advantage of the sick more than the penetrating keratoplasty? Less invasive, smaller surgical incision, no sutures, fast visual